Hello, this is going to be a recorded version of the Chapter 32 lecture. I do apologize that weather that is keeping us from coming to class has already begun, so I'm hoping it's not too distracting in the background on the audio here. So, like I said, we're going to cover Chapter 32, the lecture that we would have had during class, had we not had this lovely weather interruption. So this begins on textbook page 536. And as you can see, our PowerPoints are going to start with figure 32-1, which is actually on textbook page 537. This is depicting those endocrine glands. These are the glands that are responsible for our endocrine system and producing the hormones. So you'll see in the introduction there on textbook page 536 that the endocrine system is a collection of glands that produce hormones to help regulate the body's growth, metabolism, and sexual development and function. In fact, hormones, which are transported to tissues and organs throughout the body, influence every cell in some way. Because of the glands of the endocrine system are ductless, the hormones they secrete are released directly into the bloodstream and travel through the circulatory system to reach the specific target organs where they exert their primary effects. The nervous system is considered the mass communicator of the human body, and hormones are the chemicals that do the communicating. Endocrinology is the study of the chemical communication system that controls a large number of physiologic processes. It is also the study of hormones, their receptors, and the intracellular signaling pathways that they follow and call upon. As mentioned, all cell types, organs, and processes are influenced by hormone signaling, though some more strongly than others. Growth from birth to adulthood involves the endocrine system. Critical GHs are growth hormones and other contributing hormones. So that's what we're going to get into here within chapter 32. So let's start by looking at the anatomy of the endocrine system on textbook page 537. So as mentioned there in that introduction, our endocrine system is an internal communication system. The major parts of the endocrine system include the hypothalamus, which controls the pituitary gland, and the pituitary gland itself, which is also called the hypophysis. It controls the thyroid, parathyroid, pancreas, adrenal glands, and the gonads. On textbook page 538, we're going to look into our hormones. We're going to define them a little bit, talk about them just a tad so you understand where we're going with this. So hormones are the chemicals that transfer information and instructions from one set of cells to another. Each hormone affects only the cells that are genetically programmed to receive and respond to its message. It's how we prevent cross communication, thus causing chaos within our systems. So we have two groups of hormones depending on their structure, and that is the steroids, which are slow acting or long lasting, and their names usually end in "rone," like testosterone and progesterone. And two, the peptides and amines. These are made of proteins. They are fast acting but short lived, and they include insulin and the antidiuretic hormone, among others, or ADH. So let's look at these endocrine glands beginning there at the bottom left of page 538. We're going to start with the hypothalamus. It controls many body functions, maintains our homeostasis, which is a stable and constant environment for our bodies. It produces releasing factors, or RH, as well as tropic or stimulating hormones, TH, and provides negative feedback, which is the process by which the body is able to return to homeostasis when something gets out of whack, so to speak. Next, we have our pineal gland at the bottom right of page 538. This is part of the diencephalon of the brain. It also produces melatonin for our sleep and wake cycles. Next is the pituitary gland. They're on page 539. So the anterior secretes hormones that regulate the activities of other glands. Figure 32-2 there at the bottom left on page 539 depicts the pituitary gland and where it is in relation to the hypothalamus, the thalamus, the stalk within the brain. And they give you a close-up excerpt showing you where the hormones release. Our thyroid, on textbook page 539 on the right-hand side, we get into the thyroid and the parathyroid. So the thyroid is a small gland. It weighs less than an ounce. It's located in the front of the neck, and it's made up of two lobes that lie along the windpipe and are joined together by a narrow band of tissue called the isthmus. It tends to look a little bit like a butterfly. The thyroid is directly related by the anterior pituitary gland and indirectly regulated by the hypothalamus. So we have follicular cells that are going to secrete iodine-containing hormones, thyroxine or T4, and triiodothyronine or T3. And parafollicular cells will secrete the hormone calcitonin. This affects body parts and functions that regulate growth. Our parathyroid is going to control the amount and production of calcium. On page 540, there's a workplace wisdom box regarding thyroid cancer statistics that says every year approximately 15,000 new cases of thyroid cancer are diagnosed. So it's a pretty predominant issue. So just beneath that workplace wisdom box on page 540, we're now going to look into the adrenal glands. These are at the upper part of each kidney. They almost look like sort of a cap or a hat sitting on top of each kidney. They consist of the adrenal medulla, or the inner or center part of the adrenal gland, and that is what secretes epinephrine during sympathetic activation. And our adrenal cortex, or the outer part of that adrenal gland, secretes two types of corticosteroids, the glucocorticoids and the mineralocorticoids. Table 32-1 on the top right of textbook page 541 gives you those glucocorticoids and the mineralocorticoids. Textbook page 540 in the upper right-hand corner is figure 32-3, which is depicting your adrenal glands. So you can see what I mean there, about how they kind of sort of sit on top of the kidneys like a hat or a cap. And in that circle to the lower left of the illustration there, you'll see they've done a cross-section of the adrenal glands so that you can see the difference between the medulla and the cortex areas. Now we're going to look at the pancreas. I apologize. First, we have a workplace wisdom regarding the mineralocorticoid fludrocortisone that tells us that fludrocortisone is a therapeutic gonadal hormone used to treat Addison's disease and salt-losing adrenogenital syndrome. And that info box or workplace wisdom box is on page 541 if you did not see where that was. Now we'll get into the pancreas, which is an endocrine gland and a digestive organ. So it does two things. Our pancreas secretes hormones including insulin, glucagon, and somatostatin. That's how it performs as an endocrine gland. It also secretes pancreatic juice with digestive enzymes to help absorb nutrients from the small intestine, thus making it a digestive organ as well. Our gonads, gonadotropin releasing hormone, or GnRH, is released by the gonads, released by the hypothalamus, precipitating the onset of sexual maturity in both males and females. GnRH stimulates the release of luteinizing hormone, LH, and the follicle stimulating hormone, or FSH, from the anterior pituitary, which stimulate the production of sex hormones or the gonads. So gonads for the males would be the testes, and for a female, we would be talking about the ovaries. So the female sex hormones, I'm on the right-hand side of text page 541 now, include estrogen, which is responsible for the development of our secondary sex characteristics, and also the formation of osteoblasts, inhibition of osteoclasts and bone loss, as well as progesterone, which prepares the lining of the uterus for implantation of a fertilized egg or an ovum. For the male, their sex hormones are also referred to as androgens. That main sex hormone is testosterone, and it is produced in the testes. It's going to stimulate the development of male sex organs and maintain secondary sex characteristics of the male. They also produce progesterone that is produced in the adrenal gland and the testes, and progesterone for them plays an integral part in maintaining their healthy prostate. Table 32.2 gives you the endocrine glands and the hormones that they secrete, and also provides you a brief synopsis of the hormone's function. That table can be found on textbook pages 542 to 543. I'm not going to read through this, as I usually do not, but I can tell you there's quite a few questions that come out of this particular table. I would familiarize myself with it if I were you. Okay, I'm going to continue with estrogen replacement therapy and menopause there on textbook page 543. So, estrogen replacement therapy is the prescribed treatment for common symptoms associated with menopause, such as those hot flashes and vaginal dryness. Also provides prevention of bone fractures associated with osteoporosis and a reduction of the risk of heart attacks and strokes. And for excessive and painful uterine bleeding, there are topical or vaginal estrogen creams available for vaginal or vulva atrophy that is associated with menopause. So estrogens are going to reduce LDL and raise HDL cholesterol, and they also have some bone promoting effects. Estrogen replacement therapy is implicated in liver disease, endometrial cancer, and maybe breast cancer. It's also linked with increases in gallbladder disease and abnormal blood clotting. There's no evidence for effectiveness against nervousness symptoms and or depression associated with menopause. So it's going to help with some of the physiological issues, not so much the mental aspects. So the bullet points along the right-hand side of textbook page 543 are going to provide some indications for estrogen replacement therapy, and those include moderate to severe vasomotor symptoms that are associated with menopause, atrophic vaginitis, prorosis of vulva, which is atrophy and shrinkage of skin of the vagina and vulva. It's also indicated for female hypogonadism and hysterectomy. Estrogen replacement therapy is indicated for primary ovarian failure as well as breast cancer, where there it's only palliative therapy and only in appropriately selected women and men with metastatic disease. Estrogen replacement therapy is also indicated in prostatic carcinoma. Remember at the beginning we were talking about fighting disease with the opposite sex's hormone. Gentlemen have a prostate, ladies don't, so we might use estrogen to for palliative therapy of advanced prostatic carcinoma disease states. However, this is the second set of bullet points on the bottom right of textbook page 543. There are contraindications for estrogen replacement therapy. So estrogen replacement therapy should not be utilized when we have undiagnosed abnormal genital bleeding. If there is a known or suspected or a history of breast cancer, again, except in those selected patients being treated for metastatic disease. Estrogen replacement therapy is contraindicated when there is known or suspected estrogen-dependent neoplasia. It's also contraindicated when there is a history of deep vein thrombosis or pulmonary embolism. Those are clotting issues. We already established that estrogen replacement therapy can increase the incidence of clotting. So it's also contraindicated in active or recent, meaning within 1 year, arterial thromboembolic disease. Gotta love these words. Basically meaning a stroke or myocardial infarction. ERT is also contraindicated when there is liver dysfunction or disease, when there is a known hypersensitivity to the ingredients of the particular estrogenic formula, and also if there is a known or suspected pregnancy. We should not be utilizing estrogen replacement therapy. So table 32-3 on textbook pages 544 to 545 provide estrogen replacement therapy choices. It divides these down into their sources, whether it be natural sources, plant-derived progesterones. We have lab-modified estrogens, synthetic progesterones known as progestins. There are combination synthetic progesterone and animal estrogens, as well as combination synthetic progesterone and plant estrogens. Again, I would go through that table more thoroughly at your own pace. All right, and I'm picking back up at testosterone hormonal replacement. This begins at textbook page 545. So the FDA has approved testosterone hormone replacement, or THR, for weight gain for chronic nutritional deficiencies or wasting syndromes such as cancer or AIDS. It's also been approved for the relief of bone pain associated with osteoporosis and corticosteroid-induced catabolism, as well as hereditary angioedema and severe anti-metastatic breast cancer in women. It's been approved for hypogonadism and stimulating puberty in certain boys who are late starting naturally, as well as cryptorchidism, which is a failure of one or both testicles to descend. So on textbook page 546, we have a info box regarding the risks and benefits of hormone replacement therapy that tells us, in conjunction with their physician, each patient must weigh the risks and benefits before starting hormone replacement therapy. With estrogen, we have risks that increase the risk of blood clots, gallbladder disease, uterine cancers, and breast cancer. But the benefits are going to provide relief from frequent hot flashes, which is usually the chief complaint when dealing with postmenopausal women. We also have a workplace wisdom regarding androgel warning at the bottom left of textbook page 546. So androgel is a male testosterone hormone replacement product. It is an actual gel, so it's generally applied to the upper arm or the upper thigh area. And this box is warning us that androgel can be passed to another person through unwashed clothing or skin-to-skin contact. So any persons who come in direct contact with clothing or skin that has had the drug applied to it should immediately wash the area of contact with soap and water so that they avoid absorbing that testosterone within their own system. This is especially true if there is a pregnant individual in the home or family, and if there are young children. We don't want them touching the site of application or clothes that have come in contact with the product. So now I'm going to move on to the right-hand side of textbook page 546. We're going to look at the side effects of anabolic steroids. So there are a number of irreversible side effects when it comes to anabolic steroid use that affect both men and women. These a lot of times are, like I said, are going to be irreversible side effects. This can include edema, which is a swelling of the lips, hands, feet, legs, arms, and weight gain, which is going to be due to sodium and water retention. Another side effect is jaundice due to an increased concentration of bilirubin in the liver. Hepatic carcinoma after prolonged steroid use can develop. High cholesterol and the associated diseases. Increased or decreased libido. Chills. Decreased glucose tolerance. Increased serum levels of LDLs and decreased levels of HDLs, and increased excretion of creatine and creatinine. Anabolic steroid side effects that are specific to women include acne, and this is the bullet points along the right-hand side of page 46. I'm in the middle section of them. Hirsutism, which is growth of facial hair. Increases in body hair, which can become permanent. Deepening of the voice, which can become permanent. Amenorrhea, which is a loss of menstrual cycle or other menstrual irregularities. An enlargement of the clitoris, which can become permanent. Uterine atrophy. Shrinkage of breast size, as well as masculinization of female fetuses in a pregnant woman. Anabolic steroid side effects that are specific to men include infertility, impotence, which is the inability to obtain and maintain an erection, increased frequency of erections, pre-puberty penis enlargement, testicular atrophy, a decline in testicular function and decrease in spermatogenesis. So we've decreased the production of sperm. Also a decrease in seminal volume, which is going to help the sperm get to where it's going, especially if conception is being attempted. Chronic priapism. Priapism is a painful extended duration erection. Epididymitis, bladder irritability and decrease in seminal fluid volume, as well as gynecomastia and nipple tenderness. Table 32-4, the top left of textbook page 546, provides a list of androgens and their generic names. Which then brings me to the workplace wisdom box at the top left of textbook page 547 regarding federal regulation of anabolic steroids. So because of the widespread abuse, the Anabolic Steroids Control Act of 1990 was passed, thus making anabolic steroids a Schedule III controlled substance. This means that the drugs may be kept under lock and key in the pharmacy. And again, that was just because of the widespread abuse is the reason for the control schedule class change on those particular products. Moving on now into glandular disease states there on textbook page 547. So this is going to talk about some cancers such as breast, uterus, prostate gland. These things are going to be dependent upon sex hormones. So the use of opposite sex hormones appears to antagonize or inhibit tumor growth. So endocrine therapy is palliative only. All right, now let's look at some endocrine system disorders. We're going to start with pituitary gigantism on textbook page 547. This results from an excessive secretion of GH in childhood, usually caused by a non-malignant tumor of the pituitary gland. It causes the child to grow excessively and to be bigger in all areas of the body. Size and growth are going to be proportionate. If you've ever seen the old Robin Williams movie Jack, that's an exaggerated example of pituitary gigantism. So treatment would include surgical removal or radiation therapy of the tumor. Somatostatin analog medications may also be utilized, and sometimes dopamine agonists will be utilized. Pituitary dwarfism results from a lack of GH or growth hormone. The person may be somewhat short at birth. In most cases, the child's growth is normal until 6 to 12 months of age. If not, exogenous growth hormone is needed prior to bone plate fusion. Textbook page 548, we get into acromegaly. With acromegaly, there's an excessive secretion of the growth hormone during the adult years. It is characterized by enlarged bones of the cheek, hands, feet, and jaws, prominent forehead and large nose, disproportionately large arms, legs, and hands. It is usually caused by a tumor on the pituitary gland, so treatment would include removal of that tumor and or medications to decrease the growth hormone secretion and shrink the tumor. Table 32-5 gives you prescription treatments for pituitary gigantism and acromegaly, and that is found at the top of textbook page 548. On the right-hand side of textbook page 548, we'll get into diabetes. So you see on this PowerPoint slide, we have 4 types listed here. All 4 of these types, we are talking about diabetes mellitus. There's a second type, diabetes insipidus. We'll get into it in just a minute. So type 1 diabetes mellitus is typically referred to as juvenile diabetes because it generally onsets during an individual's childhood. However, there are some cases where occurring as late as young adulthood. But with juvenile diabetes or type 1, the individual's body has failed to produce insulin. It is no longer producing any on its own. These individuals are insulin dependent. With type 2 diabetes mellitus, the individual has become insulin resistant or insulin deficient. So they're not producing enough, and what they are producing, their body's not utilizing properly. It's resisting it. Thus, they may need to medicate and possibly even add insulin if they're unable to get it under control. Gestational diabetes affects about 4% of all pregnant women in the U.S. And just something about the pregnancy triggers some women to become diabetic during the course of the pregnancy. And that is what we refer to as gestational diabetes. And then prediabetes is technically not diabetes. It means that the glucose levels are higher than normal, but they're not quite high enough to classify the individual as a diabetic. And with discipline and diet and control, these individuals can sometimes maintain this pre-diabetic state for years, sometimes the remainder of their lifetime. But it does require some discipline and control. On textbook page 551, bottom right corner, you'll see we start talking about diabetes insipidus. This is a condition resulting from a decrease in or hyposecretion, which means too low of a secretion, of that antidiuretic hormone, or ADH. This is often acquired after a head injury or brain surgery. Symptoms of diabetes insipidus include high blood sugar, polyuria, which is frequent urination, polydipsia, which is excessive thirst, and polyphagia, which is extreme hunger. Table 32-7 provides prescription treatments for type 2 diabetes mellitus. That begins at the bottom of textbook page 549 and continues through textbook page 551. Next, we have table 32-8. Those are your oral hypoglycemic agents for when the blood sugar drops too low, and that is found on textbook page 552. I'm sorry. The hypoglycemics are going to lower the blood glucose. I misstated that. I do apologize. These are not for low blood sugar. These are to lower the blood sugar. I read that incorrectly. Again, I apologize. And again, that table's on textbook page 552. Table 32-9, I kind of accidentally skipped over on the PowerPoint slides there. It's at the bottom of page 552. Those are your prescription treatments for diabetes insipidus. And table 32-10 is found on textbook page 553. This one lines up a comparison between the main types of diabetes, that diabetes insipidus, the diabetes mellitus type 1, diabetes mellitus type 2. It compares the various factors, such as the onset or the mechanism of the disease, lets you compare how they measure up to one another. Hyperthyroidism. Her meaning too much. So with hyperthyroidism, at the bottom of page 553, we have an oversecretion of hormones from the thyroid gland. This is caused by Graves' disease, goiter, or postpartum thyroiditis. So postpartumly, sometimes individuals' thyroid might become inflamed. Then we have hyperparathyroidism. This is where we have an excess of the parathyroid hormone, or PTH. This is usually caused by benign tumors. Calcium is released into the bloodstream. It can weaken the bones and cause kidney stones. Table 32-11 provides prescription treatments for hyperthyroidism. That's found at the top of page 554. Hypothyroidism, PO indicating that we're insufficient or something has gotten too low. So this is when the thyroid gland does not produce a sufficient amount of certain hormones, such as thyroxine or T4, and that triiodothyronine or T3. This is caused by iodine deficiency. Hypoparathyroidism, referring to non-functioning of the parathyroid gland. This is usually going to lead to surgery to remove the gland, and which can then lead to hypokalemia. Table 32-12 at the bottom of textbook page 554 provides prescription treatments for hypothyroidism. And then osteoporosis. This is a lack of calcium causing the bones to become brittle and break. So early prevention is important. This is going to be treated with exercise, drug therapy, and diet. Table 32-13 provides prescription treatments for osteoporosis, and that's found at the top of textbook page 555. Abnormalities of the adrenal gland, textbook page 555. So the first of these that we're going to look at is called Cushing's syndrome. This is known as hypercortisolism or hyperadrenocortism. This occurs when the body is exposed to high levels of the hormone cortisol for long periods of time. Treatment's going to vary depending on the cause. It could include surgery or synthetic cortisol to maintain and balance the amount needed within the body. Also, cortisol inhibitors could be utilized, such as mitotane, aminoglutamide, metyrapone, trilostane, and ketoconazole. Table 32-15 provides your prescription treatments for Cushing's syndrome, and that is found on textbook page 558. Next, we're going to look at Addison's disease. That begins in the bottom right corner of textbook page 557. This is called hypocortisolism or chronic adrenal insufficiency. The adrenal glands underproduce cortisol and sometimes aldosterone when Addison's disease is present. This can be autoimmune, causing polyendocrine deficiency syndrome. This is also sometimes caused by long-term or overuse of glucocorticoids such as prednisone. So this could be a concern developing in somebody that needs to use steroids for a considerable amount of time. Your asthmatics, right? They're constantly being prescribed steroids. Your allergy sufferers constantly are being prescribed steroids to help control that inflammation. So if that becomes too that duration that they're on that medication becomes too long, Addison's disease developing could become a concern. Textbook page 558 contains table 32-16, and that has your prescription treatments for Addison's disease. Under that table, you will find cretinism. This is a congenital hypothyroidism that is caused by lack of fetal or childhood thyroid hormone secretion or by lack of iodine in the diet of the expectant mother. Immediate treatment with synthetic thyroid hormone is imperative. Myxedema or secondary hypothyroidism. With this, we have a thyroid hormone deficiency that is due to a lack of secretion of the thyroid stimulating hormone by the pituitary gland or lack of TRC from the hypothalamus. TRH from the hypothalamus in an adult. So treatment is with synthetic thyroid hormone, sorry. And lastly, we have Graves' disease on textbook page 559. This is known as thyroid eye disease or TED. Sometimes you'll hear it even referred to as thyroid orbitopathy. This is characterized by proptosis and swollen, congested eye muscles, making the affected eye appear larger than the other eye. It makes them appear swollen and bulging. Sometimes it looks like they're kind of coming out of the socket, so to speak. And this can affect one or both eyes. This is an autoimmune disorder in which the immune cells attack both the eye muscles and the thyroid. So these individuals are also dealing with thyroid issues because it leads to a dysfunction of both those eye muscles and the thyroid. So, summarizing chapter 32 on textbook page 559, our endocrine system is a collection of glands that secrete hormones directly into the bloodstream to be distributed to specific target cells. The primary drivers are the hypothalamus and the brainstem and the pituitary gland at the base of the hypothalamus. Hormones are going to be released in a supply and demand model. Blech. I apologize for some of the tongue ties. I hope you got through that okay. If you need me, please reach out. I am here for you. And classes are expected to resume tomorrow.